Hi, Hallie.
Hey, Dr. Brown.
How's it going?
Doing good.
Good.
Can you see my screen?
Yeah, I can.
Okay, perfect.
How's my sound quality?
Sounds good to me.
Okay. Hi, Jewel.
Hi, good morning. So, Haley, you are sharing Dr. Brown's slides.
Yeah, unless you want to do it.
No, I was just gonna do it if you didn't want to do it, so that's fine. I also have I can share or I could just send it to you, Haley, whatever is easier, to send you the Coursera files, which basically just discusses the Lord, I'm drawing a blank.
Disclosures.
The disclosures. Thank you, Dr. Brown. The
Yeah.
disclosures. So let me.
Hey, Brian.
Hey, how are y'all?
Can y'all hear my son singing in the shower? No? Okay. I can hear him. His bathroom is right next to my office.
Really, I just sent you the disclosure slides and the link that we can drop in the chat for folks to obtain their certificates. Oh, yeah, that's the link that folks fill out, but the slides is what you share.
So, Jewel, your sound quality is really good. Is mine okay?
Yes, it's good.
Okay.
Joel, do I need to open this other PowerPoint? Okay, I'm just waiting for access to it.
Oh, Jesus Lord. Let me just send it to you via email.
Jewel, I invited my other boss to this as well.
Oh, nice.
And plus or minus the urgent care. I don't know. She invited, but
Nice. The more the merrier. Get the message across.
well, that's why I was asking about the CEU. I was like, I don't know, I don't get any, but there is one.
You should be good now, Haley. Were you able to get in?
Mhm.
Okay.
Ready to let people in?
Want to go ahead and get started? Alrighty. Good morning, good afternoon to some. Welcome to a very important infectious disease echo with our very own Dr. Harry Brown today. He will be providing a comprehensive measles update, and as the title suggests, evaluation, treatment, and prevention of what's going on with measles right now. Before Dr. Brown starts, Haley, if you don't mind sharing the disclosure slides with our guests, you will be able to receive continuing education credits. But this is a disclosure that we just have to share that this activity is jointly provided by USET and Cardia Services. You could go to the next slide. So no one with the ability to control the content of this activity has relevant relationships with ineligible companies. So without further ado, Dr. Brown.
Okay, good morning, good afternoon, depending on your time zone. Today I'm going to talk about measles, which is a disease that I kind of have a lot of interest in. It's an interesting disease just from a clinical standpoint, but I also have a lot of bad memories of this disease. One of which happened when I was 4 years old. I was part of the last measles epidemic in the United States back in the early 60s. And I remember being really sick from this. I remember my eyes hurting from photophobia. And I remember I couldn't go out and play for about 3 weeks. But I also worked in Cameroon back in the late 80s in a hospital there. And I remember a 3-month period where we had 4 children who died from measles. So it's a very serious disease and one I have a lot of respect for. If you could go ahead and go to the next slide. Yeah, I just want people to know I'm an employee of USET, and I also do part-time contract work with Cherokee Indian Hospital as a clinician. I work as a hospitalist there. Any of the mistakes in this are my own and not have nothing to do with those people I work for, and I don't have any financial conflicts of interest. Next slide. So what do I want you to get out of this? Oh, well, here's the outline. I'm just going to go through the epidemiology, the pathology, talk about the clinical features, the diagnosis and treatment. And then I want to spend a good bit of time on prevention, infection control, and what you can be doing to prepare your community for any potential measles outbreak. And next slide. At the end of this talk, if you can do these 4 things, I will feel successful. If you can recognize a case of measles and know how to manage it, or at least know how, know where to start, but also know how to prevent measles, both in individuals and in your community, and know what to do just in case you have the unfortunate experience of having an outbreak in your community. Next slide. So a little bit about the epidemiology, how is it spread? Well, measles is the most contagious disease known to humankind. 90% of non-immune individuals who come into contact with a measles patient will develop measles. They'll become infected. Measles is transmitted usually either by direct contact or direct contact with infected like Kleenex tissue, or it's usually though spread by infectious droplets, respiratory droplets produced when a person either coughs or sneezes or just breathes, and this is spread by an airborne route. So that's one of the reasons that it's so contagious. It can float around in the air for up to 2 hours after the infected person leaves a room. So, there have been cases of people walking into a room 2 hours after somebody with measles was in the room, and they contracted measles that way. It's not terribly often spread on surfaces, but that is a possibility if, the virus does not last very long on surfaces, so that's not usually a big route of transmission. Next slide, please. So the incubation period of measles is about 1 to up to 3 weeks. So as quickly as 6 days up to 21 days. It averages 2 weeks though, and that's kind of the number I keep in my head. People are contagious 4 days before and 4 days after the rash appears. Back in the pre-vaccine era, it was seen mainly in late winter and early spring in the temperate regions, but in tropical regions, it would be transmitted all year long. Didn't really have much of a seasonal variation. In the pre-vaccine era, there were about 100 million cases a year worldwide, and there were 2 million deaths per year. Now that number, 2% mortality rate is mainly because in low resource countries back then, there was a very high mortality rate with measles. Up to 10% of kids that got measles would die from it. Measles was declared eliminated in our country in the year 2000, but we continue to have outbreaks pretty much every year due to imported cases. And an outbreak is defined by the CDC as 3 or more confirmed linked cases. That is, they were there was a case, and then 2 more people got measles from that first case. So outbreaks can be really small or they can be really large, like the one we're currently having down in Texas and other states, or like they're having up in Ontario, Canada right now. Next slide, please. So measles is a viral disease. It's caused by morbillivirus, which is a member of the Paramyxoviridae family. You don't need to remember that. It's a fairly large, negative sense, single-stranded RNA virus. You don't need to remember that either. There's only one serotype, and if you get infected, you have lifelong immunity from it. It enters through respiratory tract epithelium or even through the conjunctiva, through the epithelium of the conjunctiva. There aren't very many asymptomatic cases. 95% of people who get infected will get sick. They will have symptoms. There's a nice, pretty color picture. That they're not really purple. That's just artificially colored so you can see it better. But you can see the RNA inside, and the virus does have some spikes on the outside that it uses to both attach to cells and then fuse with the cell so that it can inject its RNA into the cell and reproduce. Next slide. So none of that stuff is, terribly important for a clinician. You don't have to know any of it to be able to recognize and treat virus. But again, the incubation period is pretty long for a viral disease. It first enters epithelial cells, usually in the respiratory tract. Then it spreads to local lymphatic tissue through the bloodstream or through the lymphatics. It reproduces in those lymphatic tissues. And then there's a second viremia where the virus spreads through the bloodstream pretty much everywhere in the body. At the end of the incubation period, there is first the so-called prodrome. This will last 2 to 4 days. Usually the first thing is, a child becomes tired. They may have fever, usually do have fever. They're often have a poor appetite. And then this is what I really want you to remember, the 3 C's and the P. So the 3 C's are cough, coryza, conjunctivitis. Coryza is just a fancy word for runny nose. And then the P is photophobia. So these are kind of the hallmark symptoms of measles in the prodrome phase. Unfortunately, there are a lot of things that can give you these kind of things, but the tip-off might be the combination, and especially with photophobia. So if you have somebody with no immunity who's been exposed to measles and they come down with the three C's and the P and a fever, you should suspect that they have measles and isolate them appropriately. There is an anthem. Now, an anthem is an internal rash, or at least that's the way I think of it. Uh, Koplik spots are little bitty whitish, sometimes grayish or even bluish spots that appear inside the cheeks on the buccal mucosa of the mouth. I'll show you a picture a little later. And they usually are visible about 2 days or so, 48 hours before the rash comes out. So that's another clue that you can get that you're dealing with measles. Measles is about the only thing that causes these Koplik spots. And then there's the exanthem or the rash. This usually starts 2 to 4 days after the onset of fever. It's an erythematous maculopapular rash. In other words, it's red, it's raised, and it's spotted. And it starts usually on the face, often around the hairline, and then it spreads down the body and out the extremities. So that's very classic. And when you see that, you should know that it's measles. And I'll show you some pictures. At first, it blanches. In other words, you touch it, and the redness goes away momentarily. The rash is actually caused by T cells that are attacking infected skin cells, and that's why the rash comes out. Now, this is important to know because people who have a T cell deficiency often don't have a rash. So you can have measles without a rash if you have a deficiency of T cells. Over the first couple of days, the rash will become confluent. In other words, the little spots start connecting together and you get these huge red areas on the body. It almost never involves palms or soles. So if you see a rash on the palm or soles, you ought to be thinking maybe this isn't measles, but it can. So it doesn't rule it out. The rash usually lasts about a week and then it usually desquamates or peels off. Now, an important point, this is a really important clinical point. If you have the rash and after 4 days, a kid or an adult is still having fever, that suggests that there's a complication of measles going on. And we'll get to the complications in a minute. If you can go to the next slide. So usually about 2 days into the 2 to 4 days after the rash onset, the fever goes away. And usually kids start to get better at that point. So here's just a timeline. You see that there's exposure. Way back there, the incubation period can be up to 21 days, averages about 2 weeks. Symptoms begin 4 days before the rash starts usually, but could be as short as 2 days. And then the rash lasts for about a week. But that pink area there, that's the period when people are contagious. 4 days before, 4 days after the rash onset. The rash onset is day 0. That's when you start counting as 0. So it's 4 days after the day that the rash appears. And they only need an infected, sick patient only needs to be isolated for those 4 days after the rash comes out. Go ahead and go to the next slide. So let's talk about complications. About 30% of complications will have some sort, or about 30% of cases have some sort of complication. Measles has a pretty profound effect on the immune system. It really depresses lymphocytes, and it also depresses vitamin A levels, which is really one of the reasons that vitamin A is recommended sometimes with measles. Diarrhea is one of the most common complications, but you can also get lesions in the mouth. You can get gastroenteritis. Occasionally hepatitis. So if you see elevated liver enzymes in somebody sick with measles, that's probably measles hepatitis. Pneumonia occurs in about 5 or 6% of cases, and the pneumonia can be pretty severe and is the most common cause of death from measles. But croup and bronchiolitis are also seen. There are several neurologic complications of measles. Encephalitis occurs about 1 out of 1,000 cases and has a pretty high mortality rate. About 15% of people that get the encephalitis will die from it. It has an even higher rate, though, of permanent brain damage that can present in all kinds of different ways. There's also about 1 out of 1,000 people will get something called acute disseminated encephalomyelitis. This is a demyelinating disease. Most people will recover from it. It's not usually fatal, but it can cause permanent demyelinating type damage. And then there's this really rare and strange neurologic complication called subacute sclerosing panencephalitis, or SSPE. This doesn't show up for 7 to 10 years after a measles case. Fortunately, it's rare, on the order of a few cases in a million. But it was seen, it's almost never seen today, but it was seen, occasionally back in the days before vaccine was available. And what this does is it basically just destroys the brain tissue slowly over time. It's kind of like a slow virus, and it's almost 100% fatal. But it's strange because it occurs years later. They think that it's due to a virus that can only replicate from and transmit from one neuron to another in the brain. That's why it's so slow, and you don't see it for a long time. There are also some ocular complications. Keratitis and corneal ulcerations happen, and vitamin A will help with that. You can see myocarditis or pericarditis. Another really common complication is otitis media. It's usually viral, and not usually terribly serious. Next slide, please. So this is just another slide on complications. I've already covered most of this, but the people who are at higher risk for complications are the young, that is, kids under 5, and adults over age 20. You don't want to get measles as an adult just because you're much more likely to get a complication. Pregnant women are at higher risk of complications from measles, so you really don't want to get measles when you're pregnant. And then people that are immunocompromised, like some sort of blood cancer, leukemia, and HIV infection. Now, if you're immunocompromised, complications occur about 80% of the time. So it's really bad for an immunocompromised patient to get it. And again, they often don't get the rash. 30% of them won't get a rash because they have a T cell deficiency. So it's in an HIV infected patient who's not vaccinated for measles, they have about a 40% mortality rate. So next slide, please. And again, death occurs in 1 to 3 out of 1,000 cases. So this is what the rash looks like. Here you see on the left, this child, the rash starts out on the face, usually around the hairline. On the right here, you see how there's a confluence of the rash lesions. Next slide. The rash will start to clear where it started. So it starts clearing first on the face and then clears gradually downward and outward on the extremities. And then here's a picture of Koplik spots. It's really hard to see, but they're described as grains of salt because they're only 1 to 3 millimeters, which is really small. And they're on this sort of reddish background. I mean, the inside of the mouth is already red, but it's redder. And they're sometimes pretty hard to see, but when you see them, you're dealing with measles. Next slide. The World Health Organization has a clinical case definition of measles. If you're in a resource-poor country where you can't test for it, the case definition is fever, a rash, a morbilliform rash, measles rash, and at least one of those three C's. So if you're in a third world country where you can't test, and you get a kid with a fever and a rash, and they've got either cough or coryza or conjunctivitis, you're dealing with measles. Next slide. So what about laboratory testing? How do you diagnose? Well, here in a resource-rich country like the United States, you should do two things if you suspect a case of measles, even if you're sure it's a case of measles. The CDC wants laboratory confirmation. So get a swab of the nose. You can also get a urine specimen and send the swab and the urine specimen for PCR for measles. Doing a urine sample will up the odds that you'll get a positive test back. The other thing that you should do is draw blood for both IgM and IgG measles titers. Now, if the IgM is positive, and it'll be positive early in the course of the disease, IgM usually peaks about the time the rash starts to go away or partway into the rash, but it can be positive a little earlier. But IgG will be either low, or if they've never been vaccinated, it'll be negative at first, and then you test again 2 to 4 weeks later for IgG. If you have a fourfold rise in the titer, that's again confirmatory. So again, next slide. So you want to get a swab for PCR, and you want to get blood for both IgM and IgG antibodies to measles. Next slide. You do need to, these lab tests need to be interpreted in a clinical context. Is the person vaccinated? That would make it less likely that you're dealing with measles, although it's not, vaccination is not 100% effective, but it's close. Do they have symptoms that are consistent with measles? And is there another potential cause for the symptoms they're having? If you know that there's measles in the area, or they've been exposed, that greatly ups the likelihood that you're dealing with measles, or if the person has traveled somewhere where they're having measles. Next slide. Okay, let's talk about treatment. There is no treatment. Well, there's no specific treatment for measles. There's no antiviral therapy other than maybe ribavirin. If you have a severe measles case that's hospitalized, you can try ribavirin. It's been shown to be maybe effective in some serious cases, but it's not routinely used. It is recommended by the World Health Organization that children with measles be given a dose of measles once a day for 2 days. And here in the US, we recommend that children hospitalized with measles be given vitamin A. So the dose depends on the age. If they're under 6 months, it's 50,000 units. If they're 6 to 11 months of age, it's 100,000 units. And then if they're 1 year or older, it's 200,000 units. This is one dose each day for 2 days, and that's it. That's all you need. The vitamin A does not in any way, shape, or form prevent measles. So giving a kid vitamin A supplements is not going to prevent measles. The reason that it may help is for two reasons. One is vitamin A is levels in everybody is impacted by measles. We're not sure why, or I'm not sure why. And the other thing is vitamin A does serve some role in immunity. It is important for T cell function, and it's also important for epithelial cells. It helps epithelial cell integrity. So measles in kids that are vitamin A deficient, it has been shown to be effective in terms of mortality, but studies that were done in resource-rich countries, it didn't show any effect. So it's important if you're dealing with a kid who is or may be deficient in vitamin A, but for most kids, that's not going to be the case. Vitamin A deficiency is quite common in resource-poor countries, like 30 to 50% of young kids are deficient. Here in the US, it's more like 0.5%, so 1 in 200. Next slide. And too much vitamin A can be toxic, and they're seeing cases of vitamin A toxicity out in Texas now. So here's just a sort of summary of what we've covered so far. Measles is caused by an RNA virus. It's highly contagious. 90% of people who are susceptible will be infected if exposed. The incubation period is 1 to 3 weeks. It averages 2 weeks. The prodrome consists of fever, the 3 C's, coryza, cough, conjunctivitis, and the P, or photophobia. The rash comes out 2 to 4 days after the prodrome, starts up on the head and spreads down and out. Treatment is supportive, hydration, Tylenol for fever. 2 doses of vitamin A won't hurt, might be beneficial, but it's probably not going to help the majority of kids in this country. So let's go on to the next slide and talk a little bit about prevention. So this slide just shows that in America, in the United States, prior to the vaccine being introduced in 1963, we had about 500,000 reported cases a year. It was probably a lot higher than that. After the vaccine was introduced in 63, you can see that there was a dramatic fall in the number of cases to well below 100,000. There were a couple of spikes in the 70s. And then there was an uptick in cases in the late 80s, and they were finding that there were cases in people who had been vaccinated with 1 dose, and they decided that you should get 2 doses of measles vaccine. And the reason for this is not because the vaccine isn't usually effective. It's just that there are going to be some vaccine failures, maybe from improperly stored vaccine or inappropriately administered vaccine, or just for whatever reason. About 93% of people given 1 vaccine will develop lifelong immunity. A second vaccine will get somewhere around 97 to 99% immunity. So next slide. So just a little history. It wasn't until 1954 that the virus that causes measles was isolated, but fairly quickly they developed a vaccine. One was an inactivated or killed measles vaccine. It was not very effective. But there was a live attenuated vaccine that was licensed the same year, and it was very effective. But 63 was also the last time we saw a widespread epidemic in the US because people started getting vaccinated. In 1967, they took the inactivated vaccine off the market. There were less than 1 million people that got the vaccine, the inactivated one. In 1968, they came out with an improved live attenuated vaccine. It had fewer side effects. And that's the one that we still use today. 3 years later, in 71, they combined it with mumps and rubella. And this is still the same MMR vaccine that we use today. All 3 of those are live attenuated viruses. And then in 2005, they combined varicella with it and licensed the MMRV. And we're going to talk more about these 2 vaccines. Next slide. So as I said, it's a live attenuated virus. It comes in a freeze-dried powder, and then it has sterile water that you reconstitute it with. There's no preservative and there's no adjuvant. It's grown in chick embryo cell culture, and it is fine to give with egg allergy. There's no egg involved. The vaccine contains trace amounts of neomycin that's used in the manufacturing process to prevent bacterial contamination, but this is mostly removed. It also has gelatin, and the gelatin just stabilizes the freeze-dried product so that it doesn't deteriorate while in storage. Needs to be kept cold somewhere between -50 centigrade up to 8 degrees centigrade, and that's -58 to 46 Fahrenheit. You need to use it as soon as possible after you reconstitute it. After 8 hours, it's considered to be no good. The MMR is approved for 12 months to 100 plus years. You can give MMR to anybody over the age of 12 months. You can actually give it to anybody over 6 months, but it's not technically, it's an off-license use if you use it under 12 months, but it's not harmful. MMRV is only approved for 12 months through 12 years. So if you are 13 or older, you cannot get MMRV. It's not approved for that age group. And it's also not approved for under 12 months, and we don't really know whether it causes any harm under 12. So remember, MMRV, only 12 months to 12 years. Next slide. So for just routine vaccination, it's 2 doses. You give 1 dose, preferably around 12 to 15 months of age. You give the second dose preferably around 4 to 6 years of age. Now, ACIP prefers that you use separate MMR and varicella vaccine from 1 year to about 4 years of age. And this is because of the febrile seizure risk is about twice as high with MMRV as with MMR in that age group. After age 4, there's no difference. Febrile seizure risk is pretty low with both. But the reason for this is because the MMRV contains about 7 times the amount of varicella virus as just the varicella vaccine, the single antigen vaccine. So you can talk to parents about this if, they say, I just want my kid to give 1 shot. It's okay to use MMRV. Just let them know that the risk of febrile seizures is a little higher. It's still very, very low. Also, if you use MMRV, you can't give it again until at least 3 months have passed between the 2 doses. MMR, you only have to wait 4 weeks between dose 1 and 2 if you're in a situation where you want to get 2 doses in quickly. Next slide. There are some sort of special situations. So people born before 1957, they would be 68 and above today. They are considered to be naturally immune because just about everybody got measles back then before they were an adult. So if you're born before 57, you're most likely naturally immune. Now, there are a lot of people who are naturally immune who were born after that because we still had a lot of measles cases back in the 60s and even into the 70s. Now, if they were vaccinated between 1963 and 1967, they may have received the inactivated vaccine, but they may have gotten the live one. But most people aren't going to have a vaccine record from that era. If they do, and you know that they got the live attenuated, they don't really need another dose. But if they got the inactivated vaccine, they need a dose of MMR. If people were vaccinated before 1989, the recommendation was a single dose. Now, if you got vaccinated before 89 and you know you got vaccinated, you don't need a second dose unless you fall into one of these 3 categories. You're a college student, you are going on international travel, or you have somebody who's immunocompromised living in your house, or they're your significant other or something. Or, and I put this in bold, if you're a healthcare worker. If you're a healthcare worker, you need 2 doses of vaccine. Documented doses, not, oh, I think I had MMR, when I was a baby. It doesn't count if you just have a verbal, yeah, I got vaccinated. You really need to see documentation. Everybody born after 89 should have received 2 doses of a measles-containing vaccine. There may be some situations where you want to do titers on people. I would be, if you have, well, certainly you have a healthcare worker. They don't have any documentation of having had measles vaccine, but they think they did, but they're not sure. You can do titers on those people. If it's positive, they don't need vaccinating. But if it's not positive, it doesn't mean they didn't get vaccinated. But then you say, well, you don't show any titers, so let's give you a vaccine. But you don't need to do titers on people that have documented evidence of, 2 doses uh, of a measles containing vaccine. All right, next slide, please. Now, another special situation is if you're having a local outbreak or somebody's going to go on international travel to a high-risk area. And to know what the high-risk areas are, the CDC website has that information. Look under international travel on the CDC website. You can give MMR to children as young as 6 months. And I would recommend this, but they're still going to need 2 doses after age 12 months because an infant between 6 and 12 months may not develop lifelong immunity with 1 dose or even 2 doses, although you wouldn't give 2 doses before age 12 months. So if you give it prior to their first birthday, they're still going to need those 2 doses after their first birthday. There's also the situation where you have unimmunized people who were exposed to measles. Measles vaccine, if it's given within 72 hours of exposure, may be effective at preventing measles or giving you a very mild case of measles. So it's worth doing. The other thing you can give is immunoglobulin. I would give it IV because it's a huge slug if you give it IM, and there are multiple products made that you can use. The caveat here, though, is after you've given immune globulin, you have to wait a long time before you can give a vaccine. And I've provided some references there that tell how to do all this. Next slide. There are a few medical contraindications, but this shouldn't be more than a couple of percentage of people, if that many. If somebody has a severe allergic reaction to MMR, you shouldn't give it again. Or if you know that there's a component of the vaccine that they're severely allergic to, you shouldn't give it. Somebody who's severely immunocompromised, that is a CD4 count less than 200, those people should not be given live viral vaccines, which this is. If you can get them above, a CD4 count of 200, then you can give them the vaccine. This is a real conundrum because these are the people that if they get measles, they're much more likely to die from it. But they can also have a severe reaction to the vaccine if you give them that. If somebody's on high-dose steroids for more than 2 weeks, you need to wait to give them the vaccine because the steroids may make them not mount an immune response. Pregnant women, the vaccine's contraindicated now, and you shouldn't get pregnant for at least 4 weeks after vaccination. About this is there's never been shown anybody given measles vaccine to have harm if they were pregnant. And so if somebody who's pregnant, they don't know they're pregnant, they get an MMR, you should counsel them that the measles vaccine won't hurt them. However, the rubella vaccine, it is a live virus, and if it's given during the part of pregnancy where rubella can cause a problem, well, there is that theoretical risk. So just avoid giving it to pregnant women. If there's a family history of some sort of immunodeficiency that's congenital or hereditary, check their immunocompetency before you give a vaccine. The way you do this is you do a CD4 count. As long as it's over 200, you can give them the vaccine. Also, another little caveat, MMRV, in other words, the four Proquad, I think it's called, is not approved for use in an HIV infected person. You can give MMR in HIV infection as long as their CD4 count is above 200. Next slide, please. Some precautions about the vaccine. If somebody's really sick, don't give them a vaccine if you can help it. Just wait until they're not so sick. There's this theoretical problem maybe with alpha-gal allergy because the vaccine does contain gelatin, which is a protein-derived product from animals. Alpha-gal is that strange thing that you get from tick bites where you become allergic to red meat. Sounds like a horrible thing to get. But there's a theoretical possibility that person could have an allergic reaction to MMR. So what I would do is I would vaccinate if it was indicated, but I would keep them around and watch them for a while. Antibody-containing blood products, which there are many, like if somebody gets a red cell transfusion, they get enough antibodies there that it may affect the vaccine. So you need to wait at least 3 months with that. With other antibody-containing products, it might be even longer, up to, I think, 11 months in some cases. So just look at the package insert. Somebody with a history of thrombocytopenia or thrombocytopenic thrombotic. The thing here is there's occasionally a case of thrombocytopenia associated. I would still probably give it if it's indicated. If you're going to do TB testing, do it the same day they get vaccinated. Otherwise, wait 4 weeks or you may get a false negative TB test from it. The TB test doesn't interfere with the vaccine. It's the other way around. There's some precautions with MMRV because varicella, aspirin and varicella, you can get Reye syndrome. So if somebody's on aspirin, wait 6 weeks. Somebody with a history of seizures, because it's more likely to cause febrile seizures. And also if you're taking an antiviral that's an anti-herpes antiviral, either 1 day before or up to 14 days after vaccination, that can interfere with the vaccine. So if somebody's been taking that, wait 2 weeks to vaccinate. Next slide, please. The vaccine can cause some side effects. In general, it's quite safe, but it will cause fever in 5 to 15% of recipients, can cause a rash in up to 5%. Febrile seizures are uncommon, like 1 per 3,000 to 4,000 doses, but parents don't like to see their kids seize, of course. Anaphylactic reactions are very uncommon. The highest figure is 14 per million doses, but it may be lower than that. One thing to be aware of, if you give MMR to an adult female, about 25% of them will have some joint pain that can last up to 4 weeks. It's harmless, but it's, not very comfortable, but just warn them about this. And then thrombocytopenia and measles inclusion body encephalitis have been reported, but they're both extremely rare. Next slide, please. Now, just a word about measles vaccine and autism, or MMR and autism. This is a picture of a guy named Dr. Andrew Wakefield, or at least he used to be Dr. Andrew Wakefield. He had his medical license revoked in Great Britain. He was a gastroenterologist who published a paper back in 1998. He described these 12 children that had this sort of unusual enterocolitis, or inflammation of the GI tract. And he claimed that he found measles vaccine virus in biopsies of these kids. So the paper didn't come out and say, oh, MMR vaccine causes autism. What it suggested was that there might be some kind of link to this unusual enterocolitis and measles or MMR vaccine. Now, this really got a lot of attention back then. I remember when it came out and, my eyebrows went up. So after that, there were multiple big studies done to look into this. To date, there have been 24 big epidemiologic studies, and none of them, zero, have shown any connection between MMR and autism. However, this persists, especially on social media. In 2010, the article was retracted by The Lancet because one of the graduate students who had worked on it came forward and said that some of the data was faked. It also came to light that Dr. Wakefield had been funded to the tune of about $500,000. It was some other amount in pounds. I don't remember what it was, but anyway, there was a law firm that was involved in lawsuits against vaccine producing companies that had paid Dr. Wakefield to do this so-called study. So there's no evidence that it causes autism yet. That has just been a persistent myth. All right, next slide. So just kind of in summary, measles vaccine is safe and very effective. It's a live attenuated vaccine. So as far as contraindications, think about pregnancy and immunocompromised individuals. It's a 2-dose schedule typically given between 12 and 15 months, and then at 4 to 6 years before they start school. CDC's website has a lot of excellent resources for vaccine. Okay, next slide. Just in the interest of time, I'm going to go through these pretty fast. So as far as infection control, the big important thing is to identify cases and establish a diagnosis. So you want to know, do they have symptoms that sound like measles? Have they been vaccinated or not? Do they have a travel or exposure history sometime in the last 3 weeks? Next slide. As far as isolation, people who are infected and sick should be isolated for 4 days after they develop a rash. You should always use airborne precautions in a healthcare setting, regardless of vaccination status. You need to put a patient who you think might have measles into a room. If you have a negative pressure room, that's where they should go. Everybody going into that room should use respiratory protection, such as an N95 mask or something even better. Next slide. As far as quarantine, people who are exposed should be excluded if they're not vaccinated and they've been exposed. They should be quarantined or excluded from work or school from day 5 after exposure through day 21 after exposure. So if the case, though, is confirmed, even those who were, or I'm sorry, if somebody was exposed, even if they were vaccinated within 72 hours of the exposure, that vaccine doesn't really count as, immune status, because a lot of people vaccinated even within 72 hours will still have a case and they can be infectious. So next slide. As far as definition of exposure for a healthcare person who's, if you spend any time, like 5 seconds is enough time. If you took one breath in shared airspace, you are considered to be exposed. If you go in a room where there was a measles patient for up to 2 hours afterwards, you've been exposed because the measles virus can survive in the air for up to 2 hours. Next slide. So in the healthcare setting, you just need to make sure all the healthcare workers have evidence of immunity to measles, which means documented 2 vaccines, 2 doses of a measles-containing vaccine. If you have a patient who comes in who's suspected of having it, immediately isolate them. Negative pressure room if you have it. If not, put them in a private room and close the door. And then, promote good hygiene in your facility, good cough etiquette and stuff. Next, please. Really, this is really important. Make sure that, all your healthcare personnel have had 2 doses of vaccine. If they don't have documentation of that, then do a titer, and if the titer's negative, give them vaccine. Next slide. And just minimize potential measles exposure, through education of the community. You might want to post some signs around. Next slide, please. I've already really covered this. Put them in a negative pressure room if you have it. If not, close the door. Put a mask on the patient. That will help too. Next slide. If you have a healthcare worker who doesn't have presumptive evidence, they should not even go in the room, no matter how much PPE they have. But even if you have been vaccinated, you should use PPE. That is at least an N95 or better mask. Next slide. If there are people with measles in the community, if you're having a local outbreak, you should probably consider screening all visitors for signs and symptoms before you let them in. Next slide. It's just so contagious. So let's talk about, with the few minutes we have left, some proactive steps that you can do to prepare now. Remember, measles is really serious, it's easily preventable, and you need to prepare before you have an outbreak. Next slide. So this slide is already obsolete. I made it about a week ago. There are now 607 confirmed cases of measles this year in the US. But you can see from this that it's kind of spread out throughout all age groups. 97% are unvaccinated, but 3% had at least 1 dose. Most of the hospitalizations are in the under 5 age group. And there have now, unfortunately, been 3 known deaths from this measles outbreak. The latest one was an 8-year-old girl who died, I think, this weekend from respiratory complications. Next. There's really only one effective way to prevent it, and that's to get everybody vaccinated. Community immunity, which is also known as herd immunity, will help to protect the few that can't be vaccinated. Herd immunity works because if you don't have enough susceptible people, the disease doesn't usually spread, but it's not an absolute protection. A non-immune individual is still susceptible if they get exposed. And really, for herd immunity and measles, we need somewhere around 95 to 97% of the community vaccinated. Next slide, please. How are we doing? Well, if you look across the country, the only states that have above 95% are the ones in blue. And this is for entering kindergartners. This is not for 2-year-olds. Next slide. If you look at the IHS by area, we don't have a single area right now in the IHS that has enough of a vaccination rate for herd immunity. Navajo's close. They've got 93.6. Nashville, we're 83.8 is what it looks like we are in the Nashville area. And that varies tremendously. There's at least one tribal nation that's got above 95%, but there are some that are as low as 50%. Next slide, please. So how do we improve? Well, it's pretty easy. We just need to figure out who's not vaccinated and get them vaccinated. That's easier said than done, though, but we do have some good tools. If you're using RPMS, you should be able to tell who's been vaccinated and who's not. If you have, well, everybody has a state immunization registry, and that's a very helpful tool. If you don't know how to do this, probably somebody in your facility does. If nobody in your facility does, we can help you at the Tribal Epidemiology Center or the area office, Nashville area office. So there are barriers to vaccination. Sometimes it's access to care, but it's usually vaccine hesitancy, which is, in my experience, somewhat difficult to deal with. But we need to do outreach efforts to try to reach people who haven't been vaccinated and then educate them as to why it's important. Next slide, please. You know, leverage the resources that you have. You know, getting a respected family member or community leader on board can really help with vaccine hesitancy. You know, if you have public health nurses or CHRs, they can, in some cases, take the vaccine to the patient. I know some places do that. You might need to meet with your tribal council and get them on board. Social media is very robust these days and a good place to get good information, not misinformation out. It's unfortunately, though, somewhere that misinformation is spread a lot. And then if you have other ways to spread the word, use them. Posters or other, you know, flyers and stuff like that can be very effective when used appropriately. Next slide. The message should be, you know, pretty simple. Get vaccinated because measles is a bad disease. Of course, keep it respectful always. It never helps to browbeat people who are vaccine hesitant. It's really important to listen and use motivational interviewing techniques. But the message should be that measles is very serious, can cause death. The measles vaccine is safe and effective, and it is the only way that we know of to prevent measles. Next slide. I think that's it. I've got some resources. A couple of slides here that have some clinical resources. I would like to point out on this slide, the very second bullet point there, there's a preparedness guide put out by the CDC for you to help prepare your community in the event of measles cases. I'd encourage you all to download that and look at it and see which of those steps you need to be doing. And that's all I have today. I'll take questions if we have time. I really thank you for your time and attention. And that's my contact information. I'd be happy to talk to anybody about either the disease or the vaccine or prevention. Always available at that email address or my cell phone. Let's see, we have, I don't know, do we have time, Jewel, for, I'll stay on as long as people want to. There is one question I see. Are there chronic diseases associated with measles in adults? Yes. Anything that causes immunocompromised condition makes you more susceptible to getting measles if you're not immune to it. So obviously things like HIV, if you have blood cancer like leukemia, if you have if you're on if you have a disease where you're using chronic steroids or other immunosuppressants, you know, people that have had organ transplants, diabetes, there are lots of things that can, you know, give you some degree of an immunocompromised state. And those would be people who are more susceptible to getting measles and also much more susceptible to complications. So it's really important to protect those people. Great question. Thank you, Jacqueline. Any other questions?
Thank you so much, Dr. Brown. I just also wanted to share that I dropped the link in the chat to obtain your continuing education credit. Don't see any other questions, and folks are heading out. So thank you all for joining, and have a wonderful day.
Thank you, everybody.
Thank you, Dr. Brown. That was awesome. Thank you, thank you, thank you.
Wish we had more participation, but that's
I know.
always the case. That's really why we need to do these, enduring material things so that people can access it whenever. We did
Absolutely.
record it though, right?
Yes, we did.
So people can watch it if they want to.
Perfect. Haley, you'll